y'all talked about magnification and sharpness in training class? Yeah, in imaging? Yeah. All right, so there are times that we can't have a very low OID. We want to have a low OID so that we have a image size that is more similar to the object size. We don't have any kind of magnification issues, but when we have an increase in OID, what we'll get is a decrease in sharpness recorded detail. It gets blurry, right? And how we can overcome some of that is by increasing SID. So an increase in OID is always present whenever we have lateral and oblique of the C-spine. So those views where we have a natural increase in OID, we're going to use a longer SID to compensate for that. So AP isn't all that big of a deal, but lateral, what we need to see on every spinal view is we need to see the anatomy proximal and distal to that anatomy. So for the C-spine, we need to see from the skull down to the T-spine, right? A T-spine, the upper portion of the T-spine is going to be between the shoulders. Lower portion of the C-spine may even be between the shoulders. So it's not enough of the C-spine to put the image receptor right next to the C-spine for a lateral C-spine. We have to put it down below the shoulder, which naturally gives us an increase in OID. So with the increase in OID in a chest X-ray, because of the distance between the heart and the image receptor, we increased our SID to 72 inches. We're going to do the same thing for the C-spine, lateral C-spine, and obliques of the C-spine. So there's minimal OID for the frontal views, but to compensate for the obliques and the laterals, we're going to increase our SID. All right, so the views that we're going to take of the C-spine depend on the type of exam that we're looking at. So with trauma C-spines, we're going to usually just do 3, maybe 4 views. So we're going to do AP. We're going to do AP for open mouth for the dens. We're going to do an AP axial, really. People will just call it AP, kind of like the foot. Just call it AP, but it's AP axial, really. We may have to shoot a swimmers, and we'll talk about when we're going to shoot swimmers. Some other views that we may shoot, truly the only time that we're going to shoot a 2 view would be where we have hyperflexion, hyperextension. Lateral may be included in that, so even then we may do a 3 view. Sometimes we'll shoot AP obliques, and we can shoot those PA obliques, so we'll spend the rest of the day today talking about all of those. So it's important that whenever you're studying for these, you don't study the things like the AP axial pillars view or any of those. Just stick with what we're talking about here. Okay. So radiation protection, we already talked about. Patient instructions, again, we'll talk about specific to the exams. So essential projections will be your AP open mouth, your AP axial, the AP Fuchs, we sometimes use, sometimes not. The lateral, hyperflexion, hyperextension, the obliques, and the swimmers. So the key to C-spine imaging is the occlusal plane. And the occlusal plane is the plane of the teeth, essentially. All right, so the occlusal plane of the teeth. And for almost all of your C-spine views, with the exception of one, you want the occlusal plane to be parallel or perpendicular to something. Okay, this is not textbook stuff, this is actual useful information. So what you want is the upper incisors to be aligned with the mastoid process. So the mastoid process is a knot right behind your ear, okay? So you want that relationship to be aligned to something else. A problem with using that orientation is 2 things. Number one, you're going to have some patients that don't have any teeth. This is East Texas, right? So you're going to have some patients that don't have teeth. So you can't really use that. You have to guess as to how far down their upper incisors came. The other thing, or you may have some people have some of those buck teeth just stick straight out the front. That's not very useful either. But the other thing is that if the patient's in a collar, again, what you're going to have to do in order to line those is to find the patient, have the patient show you their teeth, and then find their mastoid process reaching down inside of their collar. And again, you're going to be reaching down inside of their collar, and they're going to have a tendency to want to try to help you out and move their neck, and you don't want them to do that. So a line that parallels that line would be a line that goes from the acanthion, which is right where your nose attaches to your face, all right there at the bottom of your nose, is what we call the acanthion. And it goes out to the external auditory meatus. So that line and that line are parallel lines, okay? You can always see this line. You can always see where the patient's ear hole is, right? So instead of, you got to know this for the test, that you got to align the occlusal plane, but the line that parallels that is the acanthomeatal line, the AML. So instead of using the occlusal plane, what I recommend you use is the AML. So for your images, that AML needs to be either parallel to something or perpendicular to something in order to get the best view of it, okay? With the exception of the Fuchs, everything else centers around the AML. So for the AP axial, again, you can shoot it upright or supine. I tend to shoot mine with the patient laying down, okay? So, and the reason for that is because the flexion of the neck and the rotation of the body, I have a better control of it with the patient laying down. If you get a good outcome with the patient standing up, have at it. Up to you. You'll see tech shoot the AP with the patient standing up. I do my APs, all my APs with the patient laying down. That's AP Fuchs, AP open mouth odontoid, AP axial. So again, it's always going to be an axial. Upright or supine, shoulders the same horizontal plane, mid-sagittal plane aligned with the long axis of the image receptor. C4 in the center of the image receptor. So how many vertebrae do you have in the cervical spine? You've got 7, right? So 1, 2, 3, 4. So you got 3 before and 3 after. What does that mean you're shooting to? The middle of the C-spine, right? So, you know, just count your C-spine. And that should correspond pretty closely to the thyroid cartilage. Mid-sagittal plane of the head perpendicular, extend the chin to place the occlusal plane of the acanthomeatal line perpendicular to the image receptor. What this does is on the AP, it should put your teeth and the base of the skull right on top of each other, right like that, okay? Whenever you get your image. So it should put the two directly on top of each other. So put the AML perpendicular to the image receptor. You're going to angle 15 to 20 degrees cephalic. And the purpose for the angulation is because the joint space, the disc space, because of the lordotic curvature of the C-spine, the disc space is going to be at an angle. All right, so the purpose for the angulation is to open up the disc spaces, and the purpose for the AML is so putting the AML perpendicular to the image receptor so you get as much of the upper portion of the C-spine as possible. You're not going to see the entire upper portion of the C-spine because the mandible and base of the skull are going to be right over C1, C2. You're just not going to see it. Unless you could remove their maxilla, you're just not going to see it. So really, what we're shooting for on the AP axial is from C3 down. You might see a portion of C2, but you're going to be seeing C3 through T1. Okay, so 15 to 20 degrees. So when do you use 15? Well, think about gravity. If you're laying down flat on your back as opposed to standing upright, what do you think that cervical curvature is going to look like? With the patient upright, where is the weight? Pushing down on the spine, and it's going to exaggerate that curvature. If the patient's laying down, then where is gravity pulling on it? Is it pulling on the head, making the curvature increase? No. So you've got that weight not in the picture, and you've got gravity pulling on the center of it. So if the patient's laying down, 15 degrees. If the patient's standing up, 20 degrees. Okay? So what we're going to look for is evidence of proper collimation. Again, we're only going to see from C3 down to T2. We're going to look at the shadows of the mandible and use that to determine rotation in the occipital bone. And we want to make sure that we've got no rotation. We want to see open intervertebral disc spaces and all that. Okay, so it should look like that. This is not really an ideal APC spine because you see this big round thing right there? That's the base of the skull. So you can kind of work your way through this. If you've got the head overextended, okay, so we got the mandible, or we got the upper incisors and the base of the skull perfectly superimposed. If I got my teeth in the way, do you think you can see those teeth? So if your chin is tucked, you're going to see teeth, right? As opposed to what we've got going on here, you don't see any teeth, but you see the base of the skull, right? So what they've got going on with this one is the chin is too far extended, right? So the chin is too far back. It's not bad. It's not bad. It's just not ideal. It's not textbook worthy. So what we're going to look for is rotation, and you should be able to see rotation by looking mandible, and we don't even see the angles of the mandible because the chin is too far back, but we do see mastoid processes, and it doesn't look like we've got any appreciable rotation. We should see the spinous process, that's this density that you see right in the joint space, in the disc space. You should see that in the disc space, right? So overall, it's a decent APC spine. We don't see any kind of separation between the sternoclavicular joints, and it just looks like an average C-spine. So if you fail to align the AML with the occlusal plane, if the neck is extended, then you're going to see the base of the skull. If the neck is flexed, you're going to see flexed. You're going to see the mandible, the chin, the teeth, and all that. All right, so occasionally you're going to have a patient who can't open their mouth very well. So we saw from C3 down, and let's actually pass through this and go with the open mouth, because you've seen the open mouth. In the open mouth, what we're going to do is we're going to try to complete the AP of the C-spine. All right? You're going to work in hospitals somewhere that will ask for a 2 view of the C-spine. And understand that the only time that there truly is a 2 view of the C-spine is if you're shooting flexion and extension, that's the only thing that you're shooting. If it's a trauma situation, ER patient, and they say 2 view of the C-spine, it's really 3 view. Every time it's 3 view. Most of your hospitals probably going to say 3 view, but if it does not, then, you know, if your order says 2 view C-spine, it's going to be a 3 view C-spine. The open mouth completes the AP. You only saw from C3 down on the AP axial, so the open mouth completes the AP, all right? So what we're going to see on the open mouth, or what you should see on the open mouth, is again, on the AP, you could not see the odontoid process. And you do have fractures specifically of the odontoid process. So even if I got everything perfectly aligned, you can't see it, okay? So what we're going to do for the open mouth is we're going to, again, put the occlusal plane of the AML perpendicular to the image receptor. And then what we're going to do is, instead of using a 15, 20 degrees cephalic angulation, we're going to angle, or we're not going to angle, we're going to shoot right through the center of the mouth that's open as wide as the patient can tolerate it. So that what we should see is the odontoid process right through the middle of the open mouth. So we should see C1 and C2 through the middle of the open mouth. All right, instead of changing the orientation of the camera, I'm just going to raise those up and draw this up here. So that what we want to see on the open mouth are those lateral masses that we talked about before, okay? So So what you should see, what the open mouth should look like, is you've got the odontoid process coming off of C1, and you get these little divots right as it goes into it. So that's the lateral mass of C2. Okay, C1, what you're going to see is a little bit of a joint space, and then it's going to look like it's got a little bit of a halo going over the top of it, like that. Okay, like so. So that's the lateral masses of C1. So your odontoid process should look something roughly like that. And what we're looking to see in the open mouth odontoid is a number of different things. One is broken odontoid process. If we've got a broken odontoid, most of the time it's going to break at the base of the odontoid and possibly down into the body of the odontoid. Now think about it. You got a pencil. You know, if I took this pencil and I were to hold onto it really, really tight, just really, really tight, and I reached up and smacked it like that, where's it going to break? Is it just going to break right here? Where's it going to break? All the way where it's held most tightly, right? So the odontoid process, you do have some fractures of the very upper portion of the odontoid process occasionally. Most of your odontoid fractures are going to be at the base of the odontoid. So most of the fracture is going to be way down at the bottom for the same reason. If it's going to break, it's going to break where it's least flexible, so to speak. Okay? So we're going to look for those. We're also going to look for, so we've got odontoid fractures. What we're also going to look for is what we call a Jefferson fracture. Jefferson fractures are also known as axial loading fractures. So you got your axial spine, axial skeleton. If a patient takes a hit on the head by something very heavy, let's say a construction worker, something falls off of a building, hits him on the head, or if he falls and lands on his head, then all that weight, you saw how small C1 was, right? So all that weight coming down on the patient's head can fracture C1. So you get a fracture of C1, it's a ring-type bone. So what did we learn in the pelvis about ring-type bones? If you have a break in one place, what are we going to have?
A break in another.
Break in another place, right. So a Jefferson fracture involves a fracture of the ring of C1. So what's going to happen in a lot of cases is that what you've got are the lateral masses don't line up, but rather the lateral mass of C1 is out past the lateral masses of C2. Okay, so these are the two fractures that we're going to see on open mouth odontoid. Okay, now what you're going to see in clinicals in some cases is that open mouth odontoids are hard to get sometimes, especially if the patient's in a collar. Patients in a collar, they can't open their mouth real well. Because if you open your mouth and you've got something stuck to the bottom of your chin right there, then what's going to happen when you open your mouth? Right? Do you really want that to happen? The answer is no, you don't. Because the patient might have a broken neck. So it's hard to get them. Also, if patient's in a collar, in a lot of cases, what you're going to see is that the occlusal plane is not going to be perpendicular to the table. So if you can't get your anatomy in the position that you want your anatomy in, what do? What can you do? So the occlusal plane or your cantomeatal line is not perpendicular to your image receptor, the chin's way back like that. Could you not angle your central ray? Right? So you're going to angle your central ray parallel to the cantomeatal line or the occlusal plane. Now still, that corrects the problem of the angulation of the skull, but it does not correct the problem of not being able to open the patient's mouth. But if they can open their mouth just a little bit, then what you can do is angle the central ray so that it's parallel to the cantomeatal line, and then have the patient have a long exposure time, have the patient open and close their mouth as quickly as they can, and what will happen is that the mandible and the teeth will blur out. Okay, does that kind of make sense? What that is called is the Ottinello method. The Ottinello method is a way of us using motion to see something that we otherwise wouldn't see. Most of the time, we don't want motion, right? But in this case, motion is good. Motion blurs out the mandible so that we can see the upper portion of the C-spine. So, AP, open mouth. The upper incisors and masculine tip should be perpendicular to the image receptor. If you use the acanthomeatal line, it does the exact same thing. Angle with the acanthomeatal line if you can't get the AML perpendicular to the image receptor. Open the patient's mouth as wide as possible if the patient can, and if they're not in a collar. If they are in a collar, you may have to use motion in order to blur out the teeth, and that is your Ottinello method, often referred to as the wagging jaw. Wagging jaw, Ottinello, same thing. In order to accomplish that, though, what you're going to have is a low MA setting with a long exposure time. If you use a fast exposure time, you're just not going to see it. So you're going to need 1, 2, 3 seconds to take advantage of that. Okay. So again, you're going to look for evidence of proper collimation. You're going to make sure that you've got all required anatomy. Have a patient open their mouth real wide. Just tell them to. Most of your texts are going to tell them to just hold their breath, but the textbook and the textbook positioning recommends that you have a patient say ah, and what that does is it lowers the tongue, it drops the tongue so that the tongue kind of gets out of the way, so you don't have that added density on the over the upper portion of the C-spine. So it should look like that. We got lateral masses here and here, so we've got good alignment of the lateral masses, tells us we don't have a Jefferson fracture. We've got not perfect superimposition. The teeth are here, and the base of the skull is here, so we can still see the tip of the odontoid process. If the patient's got a fracture there, it's unlikely to begin with. Again, most of your fractures are going to be down here at the bottom. But if they've got a fracture way up at the top, it's probably not going to be all that big of a deal. So, good open mouth odontoid. So if you fail to align the AML with the occlusal plane, what you're going to have is one of two things again. Either you're going to have the base of the skull over your odontoid process, right? You're either going to have the base of the skull, indicating that your neck is in extension, or the teeth, indicating your neck is in flexion. So on the test, just, don't be afraid to move your head around and kind of understand, even if you gotta go like this and, get an idea of what went wrong with the image. So that's what the Ottinello method looks like. And what you're seeing here, this blurry looking mess, is the mandible being blurred out. But this is the base of the skull, and the teeth are up here. So they could have improved this if those two things were superimposed. So what positioning error do they have here? The neck flexed or extended? You're positioning right. It's just, what's the word? Is that flexion or is that extension?
Flexion.
That's extension, actually.
Oh.
Yeah. Yeah. Okay, so the lateral is probably the most important view of the C-spine because you can see everything, every possible fracture that you might have. You can either see directly or you can see telltale indicators the patient has a broken neck. But the open mouth odontoid is probably second most important. So it's very important to get it right. Unfortunately, because it's tough, people give up too easy. They give up too easy and they rely on a Fuch. Have y'all seen anybody shoot a Fuch yet? No? Good. I'm glad to hear that. Because for a while there, nobody was really trying to get a good open mouth odontoid, and everybody was relying on Fuchs. I'll tell you why here in a minute. Fuchs, you shouldn't do that. All right, so work very hard to get a good open mouth odontoid, and if you just can't get the tip of the odontoid process, and the doctor absolutely insists he needs to get the tip of the odontoid process, then you can rely on Fuchs, and I'll talk about what Fuchs is here in a minute. But going back to this Otnello method, could we get the tip of the odontoid on that? If we reshot that? Absolutely. Bring the teeth down. As you bring the teeth down, the base of the skull is going to go up. And it's really easy to overcorrect because the teeth are coming down at the exact same speed that the base of the skull is going up. Okay? So in a lot of cases, you'll take a look at this and say, well, patient would act like this, so I need to position them like that. No. If the base of the skull is here and the teeth are there, then it's just a subtle, his chin only needs to be tucked, probably in that case, 1/2 inch, right? So don't overdo it. But yes, you could have got a good odontoid on that view. But the Fuchs is a view that shows just the tip of the odontoid itself. All right, so the Fuchs, let's say you did a good open mouth odontoid and you got the teeth and the base of the skull perfectly aligned. You're going to have some patients sometimes that have anatomy that you just can't work with. So you got the teeth and the base of the skull perfectly aligned. It does not matter from that point what you do with the skull and the flexion and extension of the neck. If those two things are perfectly aligned, you're just not going to get it. Okay? So what you can do is align, in this case, the mentomeatal line with the image receptor. And what you can do is come up under the chin so that you project that hole right there. That's what we call the foramen magnum. And if you project, or if you align the mentomeatal line, that's the tip of the chin with the external auditory meatus, then what you can see is the tip of the odontoid process inside the foramen magnum. Okay? The problem here is that what you don't see is the lateral mass and its relationship between C1 and C2. What you will see is you got foramen magnum and you've got the odontoid process actually starts down there. So the part where you are most likely to fracture doesn't show up on this image at all. So if you had a fracture straight across here, you might see it. But if you're concerned the patient has a C-spine fracture, and really most of the time the patient's in a collar, they're going to come in with their neck in extension enough that it puts the mentomeatal line pretty perpendicular to the image receptor. It might not be perfect, but what could you do to project the base of the chin over the base of the skull, or the middle point over the base of the skull? Again, angle your central ray, right? Okay, so going all the way back to fingers and toes, what happens if we put an angulation on something and we want to see joint space? We're going to see it very well? No, it closes it up. All right, I'm going to go ahead and break this pencil to illustrate this. Most of your odontoid fractures are going to be relatively non-displaced. Here we go. Give me some light. Okay. So, again, most of your fractures are going to be at the base of the odontoid process. All right. So, if it's a non-displaced fracture, it's going to be subtle, kind of like a joint space. Match back together. So, if we've got a perpendicular relationship between the central ray and the anatomy, can you see the fracture? Yeah, you can, can't you? If though, we've got an angulation, can you see it quite so well? No, you can't. So you got a number of different things going on here. Number one, most of your fractures that you're gonna see, or that you're interested in seeing, that's good, on a odontoid process, you inherently cannot see on a Fuchs because they're gonna be too low on the odontoid process in order to see it. In the event that we've got a fracture across the middle of the odontoid process and we've got an angulation on our central ray, you're not gonna see it, okay? So every year I beat this to death, and I know I'm starting into that right now, but it's very, very important to get a good open mouth odontoid. Your go-to view, if you can't get a good open mouth odontoid, is better to do the Ottenello method in order to see, you know, the odontoid process itself because of all this. If you get to a point where you've done absolutely everything that you can do to get a good open mouth odontoid and you've seen as much of the odontoid itself, the dens itself, and you just can't see the tip, now this is your go-to. But only after you've exhausted everything else. All right, so starting, I don't know, maybe 10 years ago, I was even harder on this view than I am now. I used to say this is worthless, absolutely useless. Why did I say that? Well, kind of is, right? Because this is where your fractures are going to live, and this fracture is probably going to be closed up if you put an angulation on central ray. But it's a part of some of the hospital's protocols shoot open mouth, or to shoot a Fuchs. This is Fuchs. This is open mouth odontoid. Okay, so some of the protocols are to shoot a Fuchs. Yes, shoot a Fuchs when all other possibilities are exhausted, and only then do you shoot a Fuchs, or if somebody requests it. So I can't say it's worthless anymore because it's protocol in some hospitals. But you familiar with the saying, you lay down with dogs, you get up with fleas? Yeah, this thing lays down with dogs, okay? Maybe not useless, but it's that close to being useless. All right? So good open mouth odontoid, maybe an Ottenello method. In all honesty, you probably should be able to get good enough with open mouth odontoid if you do everything right. So, the Fuchs is the only view of the C-spine that you don't have the acanthomeatal line perpendicular or parallel to something. Okay, so the AP is going to be perpendicular to the image receptor. The open mouth odontoid perpendicular to the image receptor, the Ottenello method perpendicular to the image receptor. Fuchs, the mentomeatal line is going to be used, and that's what it looks like. Let's see, you don't see the bottom down here. Okay, so lateral is absolutely the most important view. You see everything on the lateral. So if at all possible, I'm going to have my patients upright for the lateral because they can get their shoulders lower. That's number one. Number two, they can get a better inspiration. If we need to do flexion and extension, we're going to do them upright anyway. So, and you can get 72 inches a whole lot better with the patient upright. So, if it's a walk-talk patient, they're going to be upright. Some of your hospitals, even if they come in on a backboard, after the ER doc clears the patient from the backboard, they'll be shooting upright C-spines after they get them off the backboard. So we got to back up 72 inches because we got a natural increase in OID. We're going to align the AML, the acanthomeatal line, parallel to the floor. We're going to center again at C4. So mid-sagittal plane is going to be parallel to the image receptor. Mid-coronal plane is going to be perpendicular to the image receptor. It's very important to have the patient in the same horizontal plane. If you tell the patient, just like in a chest x-ray, you tell the patient, put your side up against there, they're going to have a tendency to lean into it, okay? So have them put their feet straight up under them, have them stand up straight. Put their arms and their hands behind their back. Okay, tell them to join their fingers together behind their back. And before you make your exposure, what you're going to do is you're going to have them straighten their elbows. And what that's going to do is it's going to rotate your shoulders backwards and it's going to pull them down. And right before you shoot, you're going to have them taking a big deep breath, blow it all the way out. It helps get the shoulders down. And then shoot after they finish blowing the breath out. Okay? So if, though, the patient is, in a trauma situation, then you're going to have to shoot cross table. And if you're shooting cross table, then what you probably should do, provided the patient doesn't have any kind of shoulder injuries or arm injuries, is have somebody else pull the patient's shoulders down. If the patient's conscious, tell them what you're going to be doing so that they don't pull against you. Just tell them I'm going to be pulling your shoulders down. Just relax your shoulders and you're going to pull them down. I recommend that, if you work in a hospital where some hospitals will make these drapes that you can put on over the patient's head and pull. It's made out of a double layer or triple layer sheet. Then have one person pull. And the reason I say one person pull is because in a lot of cases what you'll have is two different people pulling at a different rate. So if you have one person pulling real hard and one person not pulling very hard at all, then what you're going to have is, instead of both shoulders coming down equally, is one coming down and you're going to twist the patient a little bit, and the other one, relatively speaking, is going to go up, which is going to get you less of the C-spine than having a single person pull. Okay? So the key here, though, is that your image receptor needs to be much higher than what you would think that it would need to be. Okay, so it needs to be 1 inch above the external ear attachment. So what we're talking about is right there, right? So go 1 inch above that. The easiest thing to do is to imagine where their temple is and put the image receptor right at about the temple. And the reason for that is because, can you see where these two things point backwards and these tiny things kind of point forward? That's where the pituitary gland sits. And pituitary is irrelevant, really, for this, but that structure is what we call a sella turcica. And sella turcica is Latin for Turkish saddle. And again, that's pretty irrelevant, but coming off of the back of the sella turcica, that right there is what we call the dorsum, or the posterior sella. And what we want to see is the posterior sella pointing directly to the tip of the odontoid process. If we've got some sort of alignment that shows the lateral C-spine of the odontoid process posterior to the dorsum sella, so that the dorsum sella is pointing anterior to the odontoid process, you remember that ligament I was showing you? It's ruptured. Okay, so the patient's got a broken neck. That may be the only indication that you got that the patient's got a broken neck. Okay, so it's important to get that image receptor high enough to see the sella turcica so they can follow that line down and hopefully see whether or not it's pointing to the tip of the odontoid process. Very important. Okay, so top of the image receptor higher than what you think that you should see just for the neck, because you want to see the sella turcica. So put the top of your collimated field at the temple. Okay. The clivus is really your dorsum sella, so it should point to the tip of the dens or the odontoid process. Okay. So lateral C-spine, regardless of whether they're upright or laying down, it's all going to be the same. Center of C4, get the shoulders down, if at all possible. AML parallel with the floor, with the patient upright, perpendicular to the floor when the patient's cross table. And again, if the patient's in a C-collar, that's not really going to apply. So the reason for that, the parallel to the floor with the patient upright, is because if the patient's chin is tucked, then what we're going to have is the mandible over the anterior portion of the C-spine. Okay? If the chin is extended, then what we're going to have is the normal spreading of the spinous processes are going to be all crunched together. Okay? So with that relationship with the acanthomeatal line parallel to the floor with the patient upright or perpendicular to the floor, providing the patient's not in a collar, then, you know, we're gonna keep the mandible off of the anterior portion of the C-spine, or we're gonna keep from compressing the posterior C-spine if the chin is extended too far. So what we want to see is from, again, the solitary skull all the way down to T1. So if T1 is not demonstrated, then, you know, one of two things happen. Either the patient's got broad shoulders, that, you know, you've done everything that you can do. You know, you've pulled the patient's shoulders down or had them extend their elbows and you've got as much as you can. You just can't see through it because they got great big shoulders, or you didn't. One of the two. That's simple. You either didn't do enough to get C7T1, or you just can't because of the patient's body build. So if it's the latter, you know, if the patient just is too big and you've done everything that you can do, then you may have to shoot what we call swimmers. Anybody seen swimmers? Okay. So in this region, you know, again, we like a buffet, so we got a lot of big guys. And so you're gonna shoot a lot of swimmers. You should be shooting more swimmers than what you do Fuchs, just because of the patient population that we have. So if you don't see the top 1/3, then you're gonna have to do a swimmers. Remember that for the C-spine to be complete, we gotta see from the solitary scud down to T1. So if we don't see T1, then we have to shoot swimmers. So what we've got here, again, we don't see T1, so it's not high enough, but we've got 1, 2, 3, 4, 5, 6, 7. We really don't see enough T1 in order to be comfortable saying the patient doesn't have some sort of subluxation of C7T1. So this is a repeat, really. Where that AP wasn't too bad, this should definitely not have made it into the textbook. All right, so what we're going to be looking for on C-spine fractures, we talked about the Jefferson, we talked about the odontoid, and we talked about that transverse ligament rupture. But a very common fracture is a hangman's fracture. A hangman's fracture is a subluxation of a posterior arch fracture, but a subluxation of C2 over C3. So subluxation, you see the way you can follow the anterior curvature or the anterior border from one vertebra to the next. The subluxation means that instead of being lined up like that, it's like that, okay? So with a hangman's fracture, that's where that's going to occur. In addition to that, what we're going to see is the soft tissue just anterior to the C-spine is going to be bowed way out. So you can't really see it on this, but at home you should be able to see the separation between the windpipe, which is here, so you get the pharynx, and the soft tissue. What it's going to do is it's going to displace that air. All right, so the soft tissue here is going to be swollen significantly. It's going to indicate the patient has a fracture. Another type of fracture that we have is what we call a teardrop fracture. And that's where we have just a small fracture, a portion. It almost looks like an avulsion. It looks insignificant off of the lower portion of one of the vertebrae. So we might have just a little snap right there, and it kind of looks like a teardrop. That's why they call it a teardrop fracture. And the fracture itself is not all that significant, but it's kind of like that Massino fracture in the tib fib. You remember talking about that? Same situation. You've got that, you know, kind of like a compression sock running all the way up through the spine. And a fracture is insignificant, but what you've got is a disruption of that syndesmosis. So the patient's truly a bobblehead, one of the most dangerous and probably underrepresented as far as schools go. Fracture of the C-spine is your teardrop fracture. Okay, so if you ever happen to see swelling of the prevertebral fat pad, and you see just a funny little fracture, you need to point that out to somebody before the patient moves at all. Okay. All Alright, so a little better. We see the sella turcica. You see that little U-shaped thing right there? That is the sella turcica. So you can't really see the posterior or the dorsum sella all that well on this one. So, but you can see the anterior arch of C1, and it doesn't look like they've got any kind of a displacement of C1, C2. But 1, 2, 3, 4, 5, 6, 7, and T1. Relatively speaking, that's better lateral C-spine. So swimmers is called the twining method, and it is, again, something that you're going to do if you don't see C7, T1. You're going to run into some test questions on when to do a swimmers, and for the C-spine, that's your answer. If you've done everything that you can do and you can't get T1, then you're going to do a swimmers. But on a T-spine, you're always going to shoot a swimmers. The swimmers to a T-spine is what the open mouth odontoid is to the C-spine. Always do a swimmers with a T-spine. Only do a swimmers with a C-spine if you can't get C7, T1. Okay? So make every effort to get a good lateral all the way down to T1, and if you can't, then you're going to do your swimmers or your twining method. So now back to the table. I'm going to put the patient on the table for the lateral of the swimmers, the lateral swimmers. Need to point out one test question that trips people up every year. You know, it's really a poorly worded test question, but why we don't change it, I don't know. But I'm just going to tell you what to look for. Okay. So on the test question, you're going to run into, you know, it says something about how to position for swimmers, and you put, where do you put the downside shoulder or downside humerus, and it's high under the ear, and that's what it's talking about is putting the arm up like that. Okay, so swimmers. What we're going to do for the swimmers is, again, we're back to 40 inches. I put the patient on the table because it's going to be a big exposure, and the likelihood the patient might move is greater with the patient standing up than with laying down. So what you're going to do is take the arm that's closest to the image receptor, and you're going to elevate it. You're going to put it high up under the patient's ear, like so. Okay? This shoulder, you're going to have the patient reach for the floor or reach for the feet as much as they can. What that does is it takes your two shoulders and it separates them vertically. So this one goes up and this one goes down. So that if what you're trying to do is separate the shoulders so that you can see C7T1 and the anterior alignment of the vertebra. Okay? Still though, what you have in a lot of cases is you've got separation of the shoulders, but you still can't see it very well. So what I'll do sometimes, this isn't in the textbook, this is just free, is what I'll do is I'll have a patient, get their arm up, this arm down as far as possible, and then I'll oblique them just a little bit. And I'm talking about maybe a 5-degree oblique. And what that does is it takes the shoulders and moves them this way, but it also moves them that way a little bit so that you can see a little bit better, just a little bit, tiny amount of oblique, okay? Because if you oblique too much, the radiologist is going to look at it and he's going to say, that's sloppy, go redo it. But if you oblique it just a little bit, he'll see it better and he won't even notice it's oblique. All right, so the arm closest to the image receptor, elevated, the arm furthest from the image receptor, have them reach for the floor as far as possible. And then some of your text will also, in addition to separating the shoulders this way, will angle 5 degrees caudad. And what that does is it takes that downside shoulder, okay? So you got an upside shoulder, or you got a downside shoulder. Takes the upside shoulder and projects it even lower. So between those three things, between pulling this shoulder down, angling this, and obliquing just a little bit, you might be able to see the anterior alignment. And I mean that literally. You might be able to see it. It's an ugly image. It's an ugly, ugly image, but sometimes it's all we can do to see the anterior alignment of C7T1. Okay? So, looks like that. Yuck, right? So, in addition to all this, you know, it's such an ugly image that some of your radiologists can't really make a whole lot of sense of that. Well, is that T1 or is that C7? Is that C6 or is, you know, that C5? I don't really know. So some of your radiologists won't want you to collimate down this small. Collimating this way is good, but what they'll want you to do is include C7, C1, C2. C1 and C2 are so unique looking on the x-ray that they can actually count from C1, C2. You include C5 down, they all look alike, right? So even though, you know, this is good radiation protection because you irradiated less patient than you otherwise would have, your radiologist might not be able to count that. So most of your radiologists are going to want you to include all the way up to C1 or C2, all the way down to C7, T1. Okay? Looks like that. So the only thing that you see on swimmers is the anterior alignment, so you might be able to diagnose a subluxation, but otherwise it's really just an ugly image. It's a necessary image. I'm not going to say it's the Fuchs. I'm not going to put it in the same category. It is a necessary image. It's just a last, last effort type image. Okay, so we're out of time. We'll pick up with flexion and extension on Monday and next week. If you weren't in class last week, we're working on trying to get a classroom down on the first floor that would allow everybody to be on campus all at the same time. So instead of alternating every other Monday, and instead of alternating Wednesdays and Fridays, we'll just be on campus. Everybody will be on campus for the rest of the semester. So watch your emails. I'm hoping to hear a final word today. And if so, we can pick up on Wednesday and just have class downstairs. And it will be either, it's a 0 floor, all the way down at the bottom at the garden level. So it would be either 014 or 015. So watch your emails for that. Okay? Any questions?